The following recorded program is part of the Mount Sinai Medical Center Lecture Series, offered by Mount Sinai Medical Center in cooperation with the City of Sunny Isles Beach.
My name is Katrina Rabinovich. I'm a dedicated fellowship-trained breast and women's imaging radiologist at Mount Sinai. And today I will be talking about breast cancer, mostly breast cancer screening and the technology that we use to diagnose it and what are the options available to you right now. Unfortunately, breast cancer still remains a very serious illness. It is #1 malignancy diagnosed in women in the United States and the world, and it is the second leading cause of cancer deaths among the women in the United States. As with any illness, the way to fight it is by prevention, prompt diagnosis, and appropriate treatment. This is where screening and mammography comes into place, and we have a role in fighting breast cancer. The goal of breast cancer screening is to reduce deaths from breast cancer by detecting it early, when the treatment is more effective and less harmful to women. Unfortunately, it is very difficult to diagnose breast cancer clinically because at this time there are no blood tests available that can test for it, and unfortunately, breast cancer mostly is painless, so it is clinically usually diagnosed later. And there are multiple risk factors that have been postulated to contribute to development of breast cancer, but unfortunately, 75% of all breast cancer happens in women with no risk factors and no family history. Since regular mammography screening began in the United States in the 1980s, the breast cancer death rate has plummeted by 35%, which is a very significant number. Since 1980s, there have been multiple developments in technology, and guidelines for breast screening have been updated many times, but the goal of the breast screening remains the same. Big or small, let's save them all. I want to go over a little bit of breast cancer screening, some facts and some statistics. Every year, over 231,000 women will be diagnosed with breast cancer, and roughly approximately 40,000 women will die from the disease. A woman in the United States has 1 in 8 risk over the course of her lifetime of being diagnosed with breast cancer. The incidence of breast cancer increases steadily with increasing age. It has been known for years that mammography screening is able to detect a large percentage of breast cancers before they can be clinically diagnosed or felt, and which allows the diagnosis at a smaller size at an earlier stage, and it is more likely to be curable. There have been a lot of confusion and controversy recently in the scientific literature and social media regarding guidelines for screening as far as when to start, when to finish, how often to do it. Should we do it every year? Should we do it every 2 years? And it has been a lot of misinformation and confusion, not only for the general population, but even for referring physicians. So I will go over some facts today that will hopefully help to clarify some of the points and the confusion. Nobody has ever argued that mammography does save lives. In European countries such as Denmark and Sweden, where there is universal access to healthcare and mammography programs are more organized, the data showed that the breast cancer death rate has been reduced almost by half in the last 20 years. A recent study published in one of the major epidemiology cancer journals also showed that mammography screening cuts the risk of dying from breast cancer also nearly in half. There was a recent study published in a cancer journal that showed that more than 70% of women who died from breast cancer in their 40s were among the 20% of women who were not being screened. The most rigorous scientific studies have shown that the most lives are saved by screening beginning at the age of 40 and not 50. Recent study published in the British Medical Journal showed that early detection of breast cancer, specifically with mammography, not only significantly improves the breast cancer survival, but by allowing mammography to detect cancer at an earlier stage, it allows for improved quality of life for women because they require less invasive treatment, which is also very significant because we don't just want to improve survival, we want to improve quality of life. American Cancer Society, Society of Breast Imaging, and American College of Obstetrics and Gynecology strongly insists that breast cancer screening starts at 40. There's no end to screening age. Women should be screened at any age for as long as they're feeling well. And the mammography screening should be conducted every year. The choice of 40 as the start of screening is not arbitrary. There are multiple factors that contributed to this number being selected. One of them is that breasts begin to change around the age of 40, and the incidence of breast cancer doubles at this age. Menopause can start in early 40s, and mammography is recommended before the onset of menopause. The scary statistic is that 1 in 6 breast cancers occur in women between the ages of 40 to 49. So if we eliminate this population from screening, 1 in 6 women diagnosed with breast cancer will have a very morbid outcome. 1 in 69 women will be diagnosed with invasive breast cancer in their 40s, which is also a very significant number. Screening at the age of 40 results in the greatest mortality reduction, most lives saved, and most of years of life gained. The years of life lost to breast cancer are highest for the women in the 40s because they have the highest life expectancy. 40% of all the years of life saved by mammography are in women in their 40s. The largest and the longest running breast cancer screening trials found that regular mammography screening cuts breast cancer deaths by roughly a third in all women ages 40 and over. Basically, starting screening at the age of 40 saves approximately 6,500 lives each year in the United States, rather than a screening starting at the age of 40 and being conducted every 2 years, which is a very significant number. The confusion started recently when the United States Preventative Task Force advised against annual mammograms for women in their 40s. This decision was based on faulty data and some questionable personal gains by the committee. These recommendations have been scientifically rejected by basically every major medical organization with demonstrated expertise in the breast cancer care. The panel of the Preventative Task Force did not have any breast oncologist or radiologist on the board. The federal government actually has barred Medicare and private insurance companies from considering these recommendations when making coverage determinations for mammogram. Insurance companies still cover annual mammography starting at the age of 40. And by not getting annual mammogram starting at the age of 40, there are increased chances of dying from breast cancer and the likelihood that young women will experience more extensive treatment for any of the cancers found because they will be diagnosed at a more advanced stage. The current screening recommendations by the Preventative Task Force actually could endanger women, because if followed, the screening recommendations will result in thousands of unnecessary deaths each year and thousands more women enduring extensive and expensive treatments than if their cancer had been found earlier by an annual mammogram. New American Cancer Society breast cancer screening guidelines, and actually the old guidelines that were followed by the task force, still recommend that annual screening in women at the age of 40 and older saves thousands more lives each year than screening at a later stage and doing screening every 2 years instead of doing it every year. The largest and longest running clinical trials demonstrated that screening at the age of 40 roughly cuts the death rate by 30%. The task force based its recommendations on the false claims of overdiagnosis, but the American Cancer confirms that overdiagnosis claims have been vastly inflated due to some key methodological flaws in many studies that have been debated ever since in literature. The task force also used short-term anxiety resulting from possibly abnormal mammography results to justify its recommendations. However, these feelings, which are normal and appropriate, rapidly go away with no lasting effects to women's health, and women are a lot stronger and capable of handling news than the male panel used to believe. Short-term anxiety from test results and comparatively small number of mammography false positives absolutely do not outweigh the thousands of lives saved each year by mammography. So this slide illustrates of what happens per every 1,000 of screening mammograms. approximately 100 women will return for additional mammography views or ultrasound due to something that was seen in the initial mammogram. 61 out of this number will have additional imaging, nothing wrong will be found, and they will return to annual screening. out of this number, 20 women will have something found that is likely not due to cancer, and will have a short-term follow-up at 6 months just to keep watching the finding. 19 women will end up with minimally invasive needle biopsy with no long-term consequences or complications, and 5 out of these women will be diagnosed with breast cancer. When breast cancer is found this way, the cure rate is very, very high. And these numbers apply to women who actually have previous mammographic exams. That's why it's very, very important when you go to a different facility for your mammogram that you have your prior exams with you. This is equivalent to going to see a new doctor or to go into the hospital and bringing your medical records. Because sometimes if we don't have anything to compare the current films to, the recall rate can be a little bit higher and produce a little bit more anxiety. That's why it's always advised to have your prior exams with you, which allow more quick and more accurate screening. The studies have been coming out ever since disproving the recommendations and still proving that greatest reduction in mortality based on stage of breast cancer diagnosis may be achieved when mammogram starts at 40. And actually, 2 major leaders of the anti-screening movement have been recently discredited for scientific misconduct, and they have resigned from their institutions, not surprisingly. Another concern about women not sometimes getting appropriate screening is concerns for radiation exposure. Radiation exposure from a mammogram, an effective dose is approximately 0.5 millisieverts at the highest dose. And as you can see by these numbers, it is comparable to the in-flight radiation received on a transatlantic flight from London to New York, and it's actually less than the flight from Athens to New York. So it's actually a very low number. The most radiation that people in the United States receive is received from the background. The dose that people receive during mammogram is actually comparable to a few weeks spent in Denver. It's almost the same as the average annual dose from food, which is 0.3. It's significantly less than the background dose of 3.1 millisieverts, and it's way less than radiation worker exposure that is allowed in the United States, which is 50 millisieverts. This chart just puts everything in kind of a visual perspective, and you can see that the mammogram dose is less than some of the transatlantic flights and is significantly less than annual background radiation in the United States. Another issue that have been discussed recently in the social media is concern specifically for thyroid radiation. However, the radiation dose to the thyroid from a mammogram is extremely low. Thyroid is not exposed to the direct X-ray beam used to image the breast and receives only a tiny amount of scattered X-rays. This is equivalent to about being outside for 30 minutes and exposed to natural background radiation. For the annual screening mammography from age 40 to 80, this is such a tiny amount that approximately, if put in numbers, it will mean that 1 out of 17 million of women screened will have any effects from thyroid radiation. And also we have thyroid shields that are available and that you can request and that can be applied to the neck during the exam. So we've discussed some of the concerns and issues with the screening, and now I want to go over the technology that we use in the breast imaging. There are multiple facilities around the country. The most important thing when you go and choose a center for all your diagnostic imaging is that this place is accredited by the American College of Radiology. ACR establishes very rigorous testing standards for the equipment and also for the usage protocols that reduce the radiation and validate the proper function of the equipment. The several modalities that are used currently in the mainstream facilities. The most important of them is mammography. There are different types of mammography. There is an old analog type, which involves films. There is digital, and now three-dimensional mammography is gaining momentum. Mammography can be either screening or it can be diagnostic for women that have a clinical symptom such as pain or palpable finding. Ultrasound is also used daily as a part of evaluation of mammographic abnormalities and also as a screening for women with dense breasts. Breast MRI is used also in evaluation and screening of breast cancer. It can be done with contrast for breast cancer, and it is also approved by FDA for evaluation of silicone implants for possible rupture. And then there are some other modalities that can be screening or diagnostic, such as positron emission mammography, breast-specific gamma imaging. They have not been shown very promising as far as the diagnosis of breast cancer. There's also thermography that is done by some places around the country. However, this technology has not been FDA approved. It showed very low sensitivity and specificity, and it's basically a complete waste of money. And then there are diagnostic modalities that we use, such as combined PET-CT for metastatic workup of cases of known breast cancer. There's also contrast-enhanced mammography that is gaining momentum around the country, CT with contrast, and some experimental optical imaging that is in the works in several academic centers around the country. Mammography still remains the gold standard of screening for breast cancer. It uses a low-dose X-ray system to examine breasts. And before 1980s, all mammographic units used analog or actual films for detection of the breast cancer. Since 1980s, it pretty much in most facilities have been switched to digital, where lower dose X-rays are used to produce a digital image that can be viewed on the screen, and it allows for better resolution of detail. And the significance of mammography is that it can show changes in the breast up to 2 years before a physician can feel them. So this is an example of a film screen on the right versus digital on the left. And you can see, and this is the same patient, and you can see the difference in the quality and the resolution of the image. Currently, three-dimensional mammography or breast tomosynthesis is gaining momentum. It's starting being approved by some insurance carriers, and hopefully it will become mainstream in the near future. This is an amazing technology that allows imaging of the breast in 3 dimensions. It produces CT scan-like imaging of the breast with slices reconstructed at 1 millimeter thickness. They're very high resolution, just like digital mammogram. And the significance of this technology is that it helps to eliminate overlapping of breast tissue, and it is very useful for women with dense breasts. The total dose for 3-dimensional mammography is very similar to 2-dimensional mammography. A little bit higher, but still within the appropriate range. So just quick principles of operation. X-ray tube moves in an arc across the breast. A series of low-dose images are acquired from different angles. They are reconstructed at 1 millimeter slices. So this is an example of a breast tomosynthesis compared to the 2-dimensional mammography. You can see from the first image, I don't have the pointer, but the first image with the square on it is a 2-dimensional image, and there is a subtle asymmetry. It's difficult to see. The subsequent images are from several slices from the breast tomosynthesis, and you can see that the finding becomes much more conspicuous, which means that it is easier to diagnose and it can be promptly evaluated. Breast tomosynthesis is also especially useful for visualization of architectural distortion. Architectural distortion is one of the most important markers of breast malignancy. However, it is very difficult to see on a 2-dimensional mammogram. And you can see the first image is from a 2D mammogram where the finding is very subtle, and it becomes significantly more conspicuous on the tomosynthesis exam. Tomosynthesis is not just useful for diagnosis of breast malignancies, it is also very useful in eliminating false positive recall rate, specifically for women with dense breasts, because by eliminating overlapping structures, it allows for better visualization of the breast and less women end up being called back. Women screened with tomosynthesis were approximately 15% less likely to need repeat screening, with 16 fewer repeat exams per 1,000 of women. Another modality that we use daily is breast ultrasound. Ultrasound alone is not a good screening tool. However, multiple studies have shown that mammography combined with the breast ultrasound may find slightly more breast cancers than mammography alone, especially in women with dense breasts. Ultrasound uses non-ionizing radiation and just uses sound waves to produce detailed images inside of the breast and allows mapping. And also ultrasound is mostly used for performing breast biopsies because it is the most comfortable modality for the patient and it is less invasive. So this is a selected image from a woman who had a palpable finding. She had extremely dense breasts and nothing was seen on the mammography. She had an ultrasound and you see a suspicious mass that was able to be visualized and biopsied, and the woman was diagnosed. If the woman did not get breast ultrasound, this probably would have remained undiagnosed for a while. Breast ultrasound is currently, there are multiple technologies now in development that are very promising, such as different forms of automated breast ultrasound that allows ultrasound screening to become more mainstream, and it involves an automated, different versions of sort of an automated paddle that performs the exam. This is an example of what automated breast ultrasound looks like. It not only allows for diagnosis of mammographically silent findings, but it also helps to localize them to the breast. In Mount Sinai, we're currently involved in a clinical trial of an automated breast ultrasound system called SoftView that uses additional technology such as elastography that allows mapping of the sound speed that appears as different colors to further characterize the lesions and help in diagnosis. It's not FDA approved yet, but it's currently being tested and we are part of the trial. Breast MRI is also a very important screening and diagnostic modality. Breast MRI does not involve radiation. It is actually based on physiology. Gadolinium-based contrast material gets injected and the breast parenchyma ends up taking up the contrast. And the science behind it is that more metabolically active structures take up more contrast. And we can manipulate the images and enhance the abnormal findings. And this way, cancers that are not visible in the mammography and even ultrasound can be diagnosed. Currently, breast MRI is approved and covered by insurance by for a variety of reasons. It's approved for women with a current diagnosis of breast cancer for pre-surgical planning to evaluate the extent of disease and to look for additional lesions. It's also approved as a screening modality for women who have greater than 20% lifetime risk of developing breast cancer. Also, MRI allows following a response of a malignant mass to a neoadjuvant chemotherapy. Occasionally, it is used as a problem-solving tool for evaluation of inconclusive mammogram. It evaluates for silent malignancy with lymph node biopsy-proven cancers, and also it helps to evaluate for nipple discharge in women who have negative mammographic and sonographic workup. And also MRI without contrast has been approved for evaluation of silicone breast implants for possible rupture. So this is a selected image from a breast MRI that demonstrates two abnormal findings in the breast that was not visible by mammogram. This is an additional image from a different patient that also shows a similar finding. You can see that the conspicuity of the finding is very strong, and this patient did not have anything seen on the mammography or ultrasound, and she had a very, very dense breast. And what you can see here is that the subtraction was performed and the computer manipulated it and enhanced abnormal findings. So now it became visible, and we were able to biopsy it and diagnose the woman much earlier than otherwise. The breast MRI consists of a series of dynamic images where contrast is injected, and then the images are obtained at different time intervals. And then the computer and we can manipulate the images and determine the percentage of enhancement and other characteristics that allow us to evaluate the lesions. We can use multiple intensity projection images to assist surgery to demonstrate vascularity and the extent of the disease at the time of surgery. And also we can obtain kinetic curves that assign the degree of suspicion based on the color, and also helps us in evaluating the images for possible abnormalities. And as I mentioned before, it is also involved in evaluation of the implants. The implant on the left appears fine. The one on the right has defects in it, and it was an intracapsular rupture that was impossible to see by any other way. And the woman ended up having implants replaced before they actually ruptured and the harm was done. So to summarize, annual screening mammogram should begin at the age of 40 and should be done annually. Ultrasound and MRI used for high-risk patients for screening as an adjunctive tool to mammography, and minimally invasive biopsy is available for all the diagnosis. So the bottom line is early detection is the best protection, and as some of the breast cancer survivors said, it is your life. No one can better protect it better than you. Be proactive. And another thing that I wanted to mention is that Mount Sinai has a wonderful women's health program. It is a multidisciplinary network of physicians and healthcare professionals who understand specific needs of women as a backbone of the family and also caretaker for everyone else. It consists of expert physicians that all work together to optimize the health and well-being of women. We have experienced and dedicated team that can provide diagnosis, treatment, and support services that are individually tailored. And the goal of this program is to offer women the most sophisticated medical expertise, the latest in diagnostic technology, and the most advanced treatment options available anywhere. Our comprehensive breast center that has two facilities, one in the Cancer Center in the Mount Sinai on South Beach and another one in Aventura, is a part of this network. We are accredited Center of Excellence by ACR and American Cancer Society. We have fellowship-trained dedicated radiologists and dedicated mammography-trained staff. We offer cutting-edge technology. You can get same-day results for diagnostic exam from the specialists who understand breast diseases. And as Regina have mentioned, we currently have October special. We have brochures in the back. It is a significantly reduced rate for a mammogram that is very helpful, especially for women with self-pay or women who have very high insurance deductible. And thank you so much. Questions? Yes.
Hold on.
You have to have, are there 3 tests involved before you get the MRI?
Not 3. You have to have a mammography before you have MRI. Unless the woman had mastectomy. For mastectomy patients, usually the evaluation starts either with ultrasound or MRI is also appropriate. You don't have to have ultrasound, so it doesn't have to be 3, but you have to have a mammography for the MRI. And the significance of this is because we have to correlate the images with the mammography, because mammography still remains gold standard at the current time. There is some research being conducted in the Memorial Sloan Kettering in New York. They are evaluating what's called abbreviated MRI protocols that will allow MRI to become more mainstream as a screening modality, and it's shorter and less expensive, but it's still currently in the experimental phase, and it has not been approved by the FDA. But
I think that would be the best thing. You cut to the chase.
Well,
you could see everything.
Well, the thing with MRI, it is very sensitive, but it's not as specific. And also some MRIs can miss in situ diagnosis, that it is only visible with mammography. Mammography is wonderful for early stage diagnosis of such diseases as ductal carcinoma in situ that starts usually with very, very faint calcifications, and these patients will be missed by MRI. That's why we still recommend at this time that women, even very high-risk women, that they still have mammography, and after that they have MRI. Because MRI, though, is extremely sensitive, it's not 100%, unfortunately, at this time. It's all being developed, but unfortunately no single modality can offer 100% rate of success, but in conjunction with each other, hopefully this number is much higher. That's why we recommend additional tests after mammography. If you have dense breasts, we recommend that you get ultrasound. If you have high family history and your lifetime risk of developing breast cancer is over 20%, that's why MRI is recommended, because it does pick up sometimes some things that are silent mammographically. And also another reason why we recommend getting mammography and sometimes ultrasound is also patient comfort in terms of possible biopsies. The most comfortable for the patient and easiest and less time-consuming biopsy is done by ultrasound. That's why sometimes when we see something by the MRI, we recommend targeted ultrasound that is specifically targeted to this area, and we try to see if we can see this finding by the ultrasound to save the woman for a less invasive procedure, because MRI-guided biopsies, they take time and they're a little bit less comfortable for the woman because they have to stay in and out of the magnet.
Any
Yes.
other questions?
Mhm.
Hold on a second. What is the
Sorry,
difference
next.
between a diagnostic and a screening mammogram?
Screening mammogram is done on women that do not have any findings. This is just an annual screening exam. If you have any symptoms such as focal pain, or you're feeling something palpable, or you have nipple discharge, or you notice any changes in your breast, such as suddenly, you have some redness, you have size change, this falls into the category of diagnostic mammogram, because you will basically come to the center and you will be evaluated right away, and the doctor can review your mammogram and recommend any additional images at the time. The screening mammogram, you just come in, you get your exam done. We usually read it after you have already left, and then if there's any abnormality, you get contacted by the nurse navigator, or if everything is fine, you just get a letter in the mail. So if you have any symptoms, definitely call your doctor, and they will give you a diagnostic prescription. And it is better, especially for the anxiety level, is because when you come in as a screening mammogram and you have something palpable, we always try to accommodate patients, but sometimes, things can fall through the cracks, and you will not get the result the same day, and this is definitely more anxiety-provoking.
Yes, you said yourself that mammogram does affect the thyroid.
It's extremely, extremely low dose.
Well, but it does. You see, the thyroid
One,
is a very
it can affect 1 in 17.
crucial
Yeah.
gland.
Everything is possible, but it's just the percentage of women who are affected, first of all, they have to have genetic susceptibility, to the disease or some other risk factors that when they add this tiny dose from the mammogram, it sort of pushes them over the edge. But again, we do offer thyroid shields, and this is what, radiation workers use daily. And basically with the use of thyroid shield, there is zero radiation received by the thyroid.
What about thermogram?
Thermography?
Yes.
Thermography, the claim to fame of thermography is that it uses infrared waves to determine possibly developing disease in the breast. However, so this is kind of the same principle, though it's a completely different technology as MRI, that it's supposed to be based on physiology. However, it has not shown any success in actually diagnosing the cancers. Some of the trials done on thermography have demonstrated actually success rate of detection of cancer around 30-40% for very, very large malignancies. And the whole point of screening mammography is to actually detect cancers when they're very, very small. And also thermography has a very, very high positive, false positive rate. So it basically picks up a lot of things that are not real, and it fails to pick up things that are real, unfortunately. So that's why thermography has not been approved by FDA, and it has not been endorsed by any of the medical societies that actually have expertise in the breast cancer care.
So you say
And it is expensive.
That's
It's actually
only-
costs more, in most centers than actually the screening mammogram. So what happens, and we see this sometimes, we have women coming with the thermography results that basically say there's an abnormality in the right breast. It doesn't say where it is. And, the woman ends up being very anxious and receives unnecessarily workups for something that has not been diagnostic in the first place.
So besides the mammogram, nothing ever?
Mammogram, ultrasound, and MRI at this time. There is some molecular imaging that is being in the investigative phase, where some radiopharmaceutical is injected and it binds to specific targets and possibly can diagnose breast cancer. But again, it's probably for the next 10 years, there will be different developments in the modalities that we use. But as far as something new, unfortunately, nothing currently. There are some academic centers that are working on the blood tests that possibly can aid in diagnosis of very, very early malignancy stage where the cancer cells will be showing up in the blood and they can detect them. But again, this is very experimental and unfortunately. And mammography is stressful. It is not comfortable. I mean, I know I just had my mammogram yesterday. It's even though with 3D tomosynthesis, I have to say in my personal experience, it is more comfortable because the new technology, what it does, it uses a curved paddle that fits better to your breast. There is some technology around the country where women actually assist themselves with the compression. You have a button that you can push, and that is very helpful. And actually the literature showed, interestingly, that when women have a choice of the compression, most of the women actually press harder than what the technologies would have done. So.
Are there specific thyroid conditions that would lead a woman to ask for the thyroid screen?
No. We do have thyroid shields. We do not provide them on a regular basis to women just because it has not been advised due to the very low risk, but we definitely have them. And, if you want any shielding, we have the whole body shielding that you can ask, for. This is the same as used, for x-rays, abdominal shielding that, is done for young women. And we do have thyroid shields available, and if you ask for it, you will definitely be given one.
How small a mass can the regular digital mammography detect?
It can do. I see things routinely up to 2 millimeters, 3 millimeters. But sometimes it's not even a mass that we see. Sometimes we see things before they actually become a mass. In cases of ductal carcinoma, we see some very, very faint calcifications that if left over time, they can develop into distortion, they can develop into a mass. And also what we see a lot of times is we don't even see masses yet, we just see very subtle asymmetries. And then we do additional diagnostic tests and evaluate these asymmetries with ultrasound or sometimes with MRI. And that's why we are able to diagnose cancer at an early stage, because stage does depend on the size of the mass. So the smaller it is, the better the outcome, the less invasive treatment, and the better not just survival, but also the quality of life.
And another question, for high-risk patients, is it better to have the mammography and the ultrasound at the same time?
So what we recommend for women who have high-risk status, and this is done in a lot of centers around the country, we recommend that a woman comes in and gets mammogram and ultrasound at the same time, and then 6 months after that, she gets an MRI. So you basically evaluate it with a different modality every 6 months. So instead of 1 year interval, you get evaluated every 6 months. And it gets staggered this way.
Okay, perfect. So thank you all very much. Breakfast is in the other room, and then Dr. Rabinovich is here to answer any one-on-one questions.
Thank you so much.